Everyone. Thank you for being patient while I got together a video. So I just wanted to help everyone out as they study for their boards because I know it's very stressful, very time consuming. And so I just wanted to help everyone out. So this definitely is not, a formal by any means. So, if there's something that I do say wrong on here or something that, you quite don't understand, by all means, leave me a comment. I've been a registered nurse for 15 years, but I just finished nurse practitioner school 2021, and I just took my boards a couple of weeks after I graduated. So by no means, am I a expert per se in being a nurse practitioner as far as being a doc as far as diagnosing and things of that nature. But nursing is not new to me, and I hope that it's my prayer that everyone does well on their boards, and I hope that I can help people understand better and be able to comprehend to the level that you will be able to be successful on boards as well. So I just want to, if you saw my video on the cranial nerves, I kind of at the end go into detail, well, not in extensive detail, but just in detail about how, all of our pretty much, if you went to public school in the States, we took a lot of standardized testing, and that required us to memorize things, whether that's, calculations, definitions, terms, what have you. However, as we transition, especially in the medical field, nursing undergrad, NP school, I'm sure PAs, medical doctors, anyone who's in medicine, we transition into that critical thinking type format of questions. And that's very difficult for us. We've been taught all of our lives to memorize certain things about, say a disease. And now all of a sudden we are having to break questions down into 5 different levels in order to get to the next or get to the best answer. And that was difficult for me. I know that's difficult for a lot of people because that's just the way we've been taught. So in order for me to prepare for boards, I purchased a book. I purchased 2 books actually. One is a very old book. It's about test taking skills that I think Vanderbilt still uses in terms of teaching their undergrad and graduate school level persons who are going into teaching. They still use some of these theories, which I think would be great for students that are in medicine, but you kind of got to go search for certain things if you want to kind of get a different way of thinking and kind of help you. I mean, of course, you're the one that knows best how you learn. But anyway, so I just took some of the concepts that I had learned. And so I'll be, I'll make a separate PowerPoint or presentation for that just so it doesn't get all jumbled together. But basically, there's different ways to learning. You can learn by outlines. You can learn by making flow charts or decision trees. And, these terms are not new to any of us by any means. However, when you have to group it together and learn by that way, I can show you kind of what I did to kind of see what was the best option for me in terms of studying for boards. So again, outlines is a different way to learn. Flow charts or decision trees, concept maps. We're all familiar with those. Definitely you've learned about different types of reading skills, the SQ4R technique. And that's used to improve reading comprehension. And that's survey, question, read, recite, review, and relate, which are the 4 R's. So SQ4R, again, that's survey, which is an overview or glancing at the material. The question, what are the key elements that I need to learn on this particular subject? And then the 4 R's are read slow and thoroughly, read for detail, don't skim or skip. If it's a long subject or book, break it into 20 or 30-minute increments. Once you're done, try to recall what you've learned. Rich recall could be jotting down something super quick, summary points just for memory. It's almost like a self-test. It identifies those knowledge gaps. You need to be able to apply the knowledge versus testing the knowledge. And that's very key in testing, in standardized testing versus the testing we use in boards. Again, you need to be able to apply the knowledge, not just test the knowledge. Write your own questions. People on that I went to school with, they know that I would just make up questions. Like if we had certain subjects that we were testing on, and a lot of them would ask me, like, where do you get these questions from? And those were questions really, truly, and honestly that I made up myself. Some of them were, and if I didn't make them up, I gave the source. So again, it's about just trying to like write down questions. And yeah, some of them were hard, but that's what we have to do. I mean, if it was easy, everybody would be doing it. So I try to, make yourself questions that will require you to think about what you're studying. Writing your own test questions has been found to help with thought organization and compare and contrast your facts. So again, I'll make a different one, so just not to just bore you into this. So, because we're going to be talking about cardiac just a little bit. So, just kind of like, the gist. So, acute MI, aka stroke. These are classic textbook symptoms: mid-sternal chest pain, heaviness or pressure, numbness or tingling in the jaw or left arm. Patient may be diaphoretic or have cool, clammy-like skin. The woman, of course, is different. They may present with dyspnea, fatigue, back pain, nausea, which are very different from how men, quote unquote, present. And then as far as your recap, this is kind of like, if I just gave you this PowerPoint, what would you think that this disease would be? Somebody has mid-sternal chest pain, jaw pain, fatigue, diaphoretic, clammy, back pain, nausea. So that's kind of what I mean by recapping and writing down the key facts or terms. Now, of course, the boards are not going to say, a patient comes in with all of these 6 signs and symptoms. What is the disease? No, it's not. However, when you talk about recall, it's not just about memorizing the information. Recalling is, how do I put things 2 and 2 together so that I can pull it out of my brain for later use? That's exactly what recapping or say recall is. So question, again, I made this up. An older Caucasian male presents to the clinic with a pulsating like pain in his abdomen and some low back pain. He said that the back pain is sharp and excruciating. He has a history of hypertension and smokes occasionally. The patient contributes the discomfort to recent yard work. However, on assessment, you believe he is experiencing a blank. So this might be something similar. Of course, it'll be more wordy about someone or something you might see on boards. This, of course, is not a question from boards, but I put the keywords in colors because I am a visual learner, but I also need to see certain things in color. So, when you take boards, they'll give you a pen, or they'll give you 2 pencils and a piece of paper, just for whatever you want to use it for. People use it for their dump sheet. I personally use it for my dump sheet. Also, I used it for jotting down the words. So what you see in pink and purple, I would have wrote that on my paper. Pulsating like pain in his abdomen. Okay, well, I know that just from, learning about appendicitis, cholecystitis, pancreatitis, I don't typically see those in those diseases. Definitely probably wouldn't see it in a respiratory type disease. Could I see it possibly in renal disease? Maybe, if I had a choice about that. Could I see it in cardiac disease? Possibly, depending on what's going on. So if I saw this, I would say my first thought would be a AAA. However, I could be wrong. So I would definitely want to look at what else are they experiencing. Back pain is sharp and excruciating. He has a history of hypertension and smokes. Well, I know that goes along with high cholesterol and heart disease, but also other diseases as well. But that pulsating pain in his abdomen is those key words that kind of jump out to you. So recalling that information is key to answering a question like this. So the answer would be a dissecting AAA, because those are exactly the terms that, again, going back, those are exactly the things that they would put on there to help you. Like a lot of reviewers, I took several review courses. I didn't complete them all, but I took several review courses because, again, everybody teaches and learns differently. So I wanted to see what was out there. And a lot of the things that came back, and it was very true when I took boards, is what are the key words? I mean, these are not boards designed for someone who's been in practice for, 5, 10 plus years. These are boards designed for your novice, fresh out of school nurse practitioner. So they're gonna, again, a lot of people say they're not trying to trick you. They're definitely not trying to trick you, but you need to be able to decipher some of the basic information in order to answer a question. And if you know anything, if you read anything about a AAA, then you know that a pulsating like pain in the abdomen is one of the key things that you will notice about a question in regards to a AAA. So causes, again, this is something that you may see. So a lot of times, we talk about primary hypertension, of course, being obese, certain races, say African American, family history. These are just things that, again, I've recalled from my brain. Not eating the right foods can cause, obviously hypertension, living a sedentary type lifestyle. So all the things that I just recall from my brain. Of course, there's a list of things that can cause primary hypertension. However, you need to know some of the things that cause secondary hypertension. And some of the things that cause secondary hypertension, well, first of all, what is secondary hypertension? That's something that you need to know off the bat. What causes secondary hypertension? Or, for better yet, for lack of words, what is secondary? Obviously, it's not primary. So a secondary cause of hypertension would be something related to a disease outside of, your typical, hypertensive, primary hypertensive terms. So renal related causes of secondary hypertension would be renal artery stenosis, polycystic kidney disease, chronic kidney disease. Some endocrine related causes of secondary hypertension could be hyperthyroidism. We know that if somebody said, well, why would that cause secondary hypertension? You need to be able to recall that hyperthyroidism causes an increase in pretty much everything. If you just didn't know what to pick out in hyperthyroidism, I definitely wouldn't pick terms that says sluggish or weight gain or, things like that. I would think revving up. So revving up would be my heart rate's up, my blood pressure's up. I may have, bulging, of the eyes because everything is like, bam, popping out, revving up, going full force. Hyperaldosteronism, pheochromocytoma. So even if you don't know what those things are, you need to be able to look those terms up because it might not be something as simple as hyperthyroidism. Of course, that's heavily tested on boards, but they also could throw in the pheochromocytoma, which is something that I had on my boards as well. So you need to be able to know what that is and why does it cause a secondary hypertension. Some other causes of secondary hypertension would be OSA, obstructive sleep apnea. You need to be able to know why OSA causes secondary hypertension, not just the term, oh, they're not breathing well during the night and it could cause, weight issues. It can cause blood pressure issues. The patient's tired in the morning. Well, yeah, those are very, blanketed terms, but there's a very deeper meaning behind why OSA causes secondary hypertension and why you need to be able to, help your patient fix that. It's more to it than, they just kind of like stop breathing when they sleep. Well, I mean, of course, that sounds major, but there's a deeper, relation behind that. Coarctation of the aorta. That's another thing that causes, disease rather that causes secondary hypertension. You definitely need to be familiar with these terms on here. Definitely hyperthyroidism is something that's heavily tested on. Coarctation of the aorta is something that you'll see in the ped side. And also those three terms, or the two other terms under endocrine related, you need to be familiar with that and be able to recall some information related to that as well. What is the main cause of secondary hypertension in the younger adults? Usually the main cause is renal artery stenosis. That's something that you'll see on the boards, and that's something that you need to be familiar with. Because if you can't kind of recall like some of the information related to renal artery stenosis, you need to be able to go back and be able to, find out what's going on. And you might have to bring out your patho book. I mean, I had to bring out my patho book for several different things to piece it together. So don't think that, you're going to have all this information just flowing out of your mouth. You're going to have to probably reach back and get, say your patho book or something like that in order for you to help with that. Let's see. And what is the main cause of secondary hypertension in the middle-aged adult? Because it's different. The primary cause of hypertension, secondary hypertension in the middle-aged adults, are endocrine-related conditions, such as hyperthyroidism, of course, which we talked about. And there's some other things. Obviously, weight loss, tachycardia, anxiety, fine tremors, AFib are all things that kind of coincide with hyperthyroidism. But there's also things such as, like I said earlier, pheochromocytoma and hyperaldosteronism. That can be sweating, heart palpitations, hypokalemia, anxiety, severe headaches, obviously high blood pressure, and increased sodium content. So again, if you're a visual learner, use these as a tool to kind of help you remember how to kind of like pick those things out and be able to recall it. But you do need to know about these two terms. The primary cause of secondary hypertension in the elderly is chronic kidney disease. So again, going back, you have three different age groups. You have the young, let's just go back. You have the younger adult, which is renal artery stenosis. You have the middle-aged adult, which is usually endocrine related, such as like say hyperthyroidism, pheochromocytoma, and hyperaldosteronism. And then you have your elderly adult. And the primary cause of secondary hypertension in the elderly is chronic kidney disease. So in terms of CHF, again, this is something that you need to be aware of. Come boards, you're going to have that dry cough. You're going to hear some bilateral lung crackles. You're going to be fatigued. The patient may exhibit ankle or feet edema, dyspnea, fluid in the lungs, S3 heart sounds. These are all related to CHF, and you do need to be familiar with these terms, especially the S3 heart sounds, which coincides with fluid in the lungs. Of course, fluid overload can cause edema. Fluid overload will, obviously cause some different types of lung sounds. So it all, correlates with each other, but you got to be able to recall that information. So again, use this as a visual, but another tool to recall the information. So in terms of blood pressure and eye exam, you're going to see, you'll see the two that heavily tested on boards is hypertensive and diabetic patients in terms of eye exams. So you need to be familiar with cotton wool spots, neovascularization, microaneurysms, AV nicking, copper wire, or you may see silver copper wire retinopathy. So you definitely need to be familiar with those terms. And let's see. Oh, don't know how that got antibiotics in there. All right. So in terms of just looking at my cardiac, so going back to the AAA, so for example, how would you rule out a AAA? What's the gold standard in terms of testing for AAA? So for gold standard for AAA, we're going to do an abdominal ultrasound. And if you need to go back and use, look up some of the USPTF guidelines, I mean, of course, it's free to look at. You don't have to pay for it. Print that out. Abdominal ultrasound in 65 and older, especially if they smoke. They should have this done one time in their life if they're a smoker. And again, that's from USPTF guidelines. And again, you can find that on their website. Let's see. We'll talk about meds, but let me make sure. Yep, so I'm going to have to get my other PowerPoint because I separated it when I was studying. But definitely in terms of the coarctation of the aorta, in terms of secondary hypertension, you definitely need to know how a COA will present in an infant. I mean, that's something that's heavily tested on boards. And what is considered pathologic in terms of assessment. So again, of course, all of that is fair game in terms of assessment, diagnosis, implementation, planning. So you need to know what is considered pathologic. So I can make up some questions. For example, an abdominal bruit would be considered abnormal or pathologic, I should say. So you definitely need to know that. In terms of an MI, where is that? Oops. In terms of an MI or AAA, you're gonna see dyspnea. So for example, I can make up some questions. So I'm working out, running up the steps, and I'm having dyspnea or chest pain. But when I sit down, say from running up the steps, the chest pain is relieved. The pain kind of comes and goes, and a lot of people in their on their reviews, they say the pain waxes and wanes. We heard that we had to take a Hoyer course right when we finished, or right before we finished school, and she uses the term waxes and wanes as far as chest pain. So you need to be able to answer a question. Patient V experiences dyspnea going up the steps. When she sits down, when she reaches her destination and she sits on the steps, or sits in her chair, she doesn't have any pain. The pain comes and goes, or the pain waxes and wanes. She has a history of a MI, or she has a history of stable angina. What are some things that we need to be on the lookout for? Or is this normal or is this abnormal? So it may be a pharmacology question, and they may give you a list of meds as far as should she take a calcium channel blocker to relieve this chest pain? Should she take a nitroglycerin tablet? Should she take her PRN, digoxin or whatever? So, I just made that up in my head, but you need to be able to say, okay, well, is this normal to feel this way, running up the steps? Possibly, especially if you have a history of angina. Is the angina stable or is it unstable? Again, that's, two terms you need to be aware of, because that's something that's tested on in boards. Stable angina versus unstable angina, there's a big difference in terms of how you assess and treat them. So again, I can go into detail about that in terms of, maybe just making up questions. but I will find the PowerPoint on the meds, and then we'll talk about some hypertensive meds and like cholesterol meds as well. We'll just group those together.